It's a real honour now to introduce to the stage Dr. Karin Straathof. Before we do that, please, if I may, just ask you to please watch this video.
People to know that I have 2 children and that Noah is never far from my thoughts.
To lose their adorable, strong-willed Noah at 4 years old, a twin to Ella.
Very happy, smiley, lovable little boy.
Kat and Nick Wright describe what it's like waking up in the morning every day now.
Every day you think about it, and every day you hope that no one else will go through it.
In Tesco's, and then you go past the yogurts, and then you notice the one that he loved the most.
Kat first saw something was wrong with his walk and balance when Noah was tiny, only 2.
Wasn't it? And then it was the age of 3 that we were thinking he's still asking for our hand for balance.
That's when they sent him for an MRI scan. It was 2019. The MRI found little Noah had a brain tumor, a deadly one.
You don't want to wish that on anyone.
Almost all children who get this diagnosis for this brain tumor, DIPG or DMG, diffuse midline glioma, have around 9 to 12 months to live. At the time they got this diagnosis for Noah, there was no treatment, no cure.
You just want for other parents to have the options, for other parents in a situation like us to be given something, a bit of hope.
Ladies and gentlemen, please welcome to the stage Dr. Karin Straathof. Thank you.
Hello, good evening, everyone. My name is Karin Straathof. I'm a children oncology doctor at Great Ormond Street Hospital and a research group leader at University College London. And I've been kindly asked to, given this opportunity, to say a few words to you this evening. So Noah's parents said it very clearly. DIPG is a devastating brain tumor. And every year, 30 families in the UK get this same life-changing news that their child has this brain tumor. DIPG, this brain tumor, grows very deep in the middle of the brain, and that is where very critical brain functions are happening. And therefore, it's not possible to remove this tumor with an operation. So we use radiotherapy, and that stops this tumor from growing for a period of time. But inevitably, it starts to grow again. And no chemotherapy drug or other drug so far has been shown to work and stop this from happening. So what's really needed is something different, a different way of treating this type of brain tumor. And immunotherapy, as you heard already a bit more about today, is a new and a different way of treating cancer. So it utilizes our own immune cells in our body. And our immune cells in our body are constantly going around our body on patrol, doing their day job, which is keeping us safe from infection. These cells are really specialized to tell apart healthy cells from those that are infected with a virus, for example. And once they spot one of those infected cells, they spring into action, they start to attack, clear up these cells, and then they stay on guard as well to stop that same virus from making us sick again. But unfortunately, the immune cells are not so good at spotting cancer cells. And that is really because cancer cells look much more similar to healthy cells in many ways, and therefore they go unnoticed. But we found some ways of getting around that, and that is by engineering our immune cells or introducing a new gene. And what that new gene does is it gives these immune cells the ability to see cancer. And once they can do that, they do the same thing as they do with an infected cell. They spot it, they attack, spring into action, and can clear up cancer cells. So this type of immunotherapy using engineered cells, also called CAR T cells, you may have heard that term before, has shown some very remarkable results in patients with leukemia, blood cancer. And there we've seen that children and adults with leukemia that has come back after chemotherapy, or in some cases even a bone marrow transplantation, with a single dose of these CAR T cells can go into a complete remission, meaning there is no detectable leukemia anymore. So our research group at UCL has now put a lot of effort in seeing if we can use these CAR T cells also for different types of cancer, such as brain tumors, including DIPG. And in the laboratory, we have shown that this can work, and we are now ready to start to take this forward to a clinical trial where we start to give these CAR T cells to children with DIPG. And these clinical trials are important because it allows us to answer the first questions. How many of these cells do you need to give? And what is the best way to give them? Do you give them in a drip, just like you would do for a blood transfusion, or do you give them in the fluid that goes around the brain, closer to where the tumor is? And once you've given them, do they indeed find the tumor and do what you want them to do, which is clearing up the tumor? So we work very closely with our colleagues in Stanford University, and they've already started a clinical trial like this using CAR T cells for children with DIPG. And their first results are very encouraging, showing that indeed with CAR T cells you can start to shrink these tumors. Now, clinical trials are costly, and a big barrier to open a clinical trial is to have the required funding. And it is through the incredible support of the CRIS Cancer Foundation, together with other children's cancer charities, that we now have the funding that's making this possible. So we're working hard to open the first clinical trial in the beginning of next year, and that is the first clinical trial of this type of immunotherapy in patients with brain tumors. And in the UK, we will be able to treat 12 patients from throughout the UK that have this brain tumor on this clinical trial. And this is really a huge step forward. And as Noah's mom was saying in the video, it will bring hope to those families that are faced with this devastating diagnosis. So this evening is really about looking at the future. And in my field, that of cancer immunotherapy, I think we're really at a critical point. We now have the technology, we know how to engineer immune cells and equip them to find and clear up cancer cells. And this is a unique treatment that uses living cells that can stay around in our body and stay on patrol, also stopping the cancer from trying to come back. And unlike, for example, chemotherapy, it very directly goes after the cancer cells, leaving our healthy cells unharmed, meaning less side effects. So I really believe that these engineered immune cells are the future in cancer. They have the potential to be better and kinder treatments for recalcitrant cancers, just like DIPG. So on behalf of our team at UCL and at Great Ormond Street Hospital, a wholehearted thank you to all of you for your very generous support to CRIS. And it is with the support of CRIS and other supporters of our research that we can continue our work on making this future in cancer treatment a reality. Thank you.